Hello, welcome to my channel. This is Dr. Emmanuel. Today, I want us to do a review of one of the possible PLAB2 stations. And we'll be looking at the case of depression. So this is a mental health scenario. And we'll just be looking at how to approach this station. So the scenario is that you are the foundation year 2 doctor in psychiatry department, and Adams Hickson, a 23-year-old man, has been brought to the emergency department following a suicide attempt in which he overdosed on 30 tablets of diazepam. He has been stabilized by the emergency team, and he has been told that you will be coming to see him. Perform a mental state examination on Adam, assess his risks, and discuss management with him. So this question is saying that you are the foundation year 2 doctor, the F2 doctor, and you are working in the psychiatry department. However, Adam, who is 23, overdosed on diazepam 30 tablets, and he was taken to the emergency department. The ED department, the ED team has stabilized him, and they've told Adam that, hey, look, we are referring to the psychiatry team. Someone from the psychiatry team will come and have a chat with you. And you are the doctor in psychiatry, and you've been told to go to A&E, perform a mental state examination on Adam, assess his risk, then discuss further management with him. So what's the approach like? While you are stood outside that particular room, you would have, I'm not sure how long now, you have a few seconds to prepare, to read the question and prepare yourself mentally. And then you hear the bell that tells you to go into the room. And then you hear the bell, it tells you to start. You go into the room, introduce yourself to the examiner, greet the examiner, introduce yourself. The examiner will confirm your name and your examination number, and then ask you if you are ready to start. And then you say yes, and then you now approach the patient and start your exam with the patient. So while you are preparing, you need to ask yourself, where am I? And why is that important? Why is that question important? You need to ask yourself, are you in a GP setting? Are you in A&E? That will determine what you do. Okay, are you in GP setting? Are you in A&E? Are you in the acute medical unit? Are you on the ward? Or are you in clinic? Like in a specialist clinic. All of that will determine the available resources at your, resources that are available to you at that point in time. To also determine how quickly you can get investigations ordered and get results available. So you need to know how these things work for you to do things the right way. So you are in emergency department, but you are a psychiatry SHO. So who am I? You are a psychiatry F2 doctor. Who am I seeing? You're seeing Adam Hickson, who is 23 years old. Yeah. And then why are you seeing Adam? You're seeing Adam because you are the psychiatry doctor, and Adam had overdosed on diazepam. He had attempted suicide. So this is why you're seeing him. And then what should I do? So you're meant to perform a mental state examination on Adam. You're meant to assess his risk, and you're meant to discuss management with him. So these are things you'll be asking yourself while you're preparing. So who am I seeing? I'm seeing Adam, he's 23. Why am I seeing him? You need to know, why am I seeing him? He's overdosed. What am I meant to do when I walk into this room to perform this exam? Mental state examination, risk assessment, and then you have to discuss management with Adam. You also ask yourself, what can I do? What can I offer him? So what are the possibilities? What are my chances? What are the things I could offer him? Well, I could have the option of referring Adam to the home treatment team. If I think he's fit enough to be discharged home, I could refer him to the home treatment team, who would follow him up. I could discuss with the consultant on call for possible admission if I think Adam is still at very high risk of committing suicide if I send him home. So these are things you need to ask yourself while you're preparing. And then you walk into the hall, introduce yourself to your examiner, into the room. So, hello, I'm Dr. Emmanuel, examination number, blah, 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 blah. Examiner will ask you, are you ready? You say, yes. Tell you can start. You approach the patient, you say, hello, Adam, or you confirm, you say, is that Adam Hickson? Patient will tell you yes. You say, I'm Dr. Emmanuel, I'm one of the doctors today. How may I help you? Or instead of saying, how may I help you? Say, I understand. Confirm how you want. Is it okay if I call you Adam? Patient with me, he might tell you yes or no. Very likely he will tell you yes, Adam is fine. You say, I understand you've been seen by some of my colleagues, the emergency team, because you had an overdose, and you are now stable from that point of view. But then I've been asked to come and have a chat with you. If that's okay, and Adam will tell you, yes, that's all right. So normally a psychiatry assessment takes, in real life, it lasts 1 to 2 hours. To do a proper psychiatry history taking, assessments takes not less than an hour to do most times. But now you have 8 minutes to do a mental state examination, assess the patient's risk, and discuss management. So you need to be succinct. You don't have the whole time in the world to ask all the questions. So you need to be focused, do a mental state examination, establish rapport from the beginning. That I understand you overdosed. Could you tell me why? What happened? Why did you do this? How were you feeling? Adam will tell you he was feeling very low. He felt overwhelmed. He felt hopeless. Try to find out very briefly, is that the first time he's done it or has he done it before? And he will tell you. Then you have to go into your MSE. While he's talking, you're assessing his appearance. How does he look? Does he look disheveled? Does he look clean? Does he look kempt? Does he look well dressed? Does he look, does he look sad? So just looking at his appearance. Is he over colorfully dressed? A manic patient, might be over colorfully dressed, flamboyantly dressed and all of that. His behavior, is he calm? Is he relaxed? Is he behaving aberrantly, erratically? Is he moving his limbs, recklessly? Is he having any funny behavior, unusual behaviors, or is he behaving well, appropriately? As he's talking, you're assessing his speech. Is he talking at a normal rate? Is he having a pressured speech, talking, in a pressured way? Is he talking too slow? Like a very depressed speech. And the things he's saying, do they make sense? Does his speech have any delusions in them? Is he saying things that sound, are you sure this doesn't make sense? You get the point, um, um, you know, might have delusions. He might tell you that, whenever the traffic lights, whenever he sees the right traffic light, it means something is happening. Or whatever he sees, he sees an ant crawling in his room, it means that, he sees an ant crawling in his room, it means that, something bad is going to happen, or it's a bad omen. So those are delusions, they're not concrete. Is he having, then you ask him, Adam, do you experience, do you hear voices? In your head or your ears? Do you experience hallucinations? Here people will know what hallucination means. So you ask him directly, do you experience hallucinations, like hearing voices? Do you see things or people that are not there? You ask it in a very polite and empathetic way. You could warn him, give some warning shots, like I'll ask you some few questions that might sound a bit odd. And please don't feel embarrassed. I'm asking just to assess, your mental well-being. And you ask him those questions. Do you hear voices? Do you see things that are not there? Do you see people that are not there? He might have hallucinations, but he might believe that they are real. So some patients will hear voices and they tell you, yes, I hear voices, but I know those voices are just in my head. Some will hear voices and they believe those voices are real. Some might see people and they believe those people are real. Okay, so you have to work out whether it's a hallucination or not. And the fact that they think it's real doesn't mean it's not a hallucination. Okay, so you assess his mood, ask him on a scale of 1 to 10, 10 being the best mood you've ever had, where do you place your mood at this time? Ask him, how's your mood been over the last week or over the last 2 weeks? How have you been coping? Okay. Suicidality, very important in mental state examination or psychiatry history. Do you feel suicidal? You need to ask the question directly. Do you feel suicidal? Okay. He'll tell you, oh no, doctor, I wouldn't end my life. Or yes, I felt suicidal. That's why I overdosed. I felt like I wanted to kill myself. And you ask him, do you still feel that way now? Because you want to know whether it's safe to send him home from ED and refer him to the home treatment team, or you want to know if it's not unsafe, in which case you might be considering keeping him in the hospital until he's no longer suicidal, actively suicidal. So you ask him, do you feel suicidal at the moment? He might tell you no, but also you go for that as do you have any thoughts of harming yourself in any way? He might tell you yes. You ask him, what have you thought about? He might tell you he has thoughts of using the razor blade to cut himself, give himself marks, or self-neglect, deciding not to eat. There are patients who will tell you that, not eating, starving themselves gives them that, similar feeling to maybe suffocating themselves, so they see starvation as an alternative to physical self-harm. So you ask him things like that, and then check his insight, whether he knows. It typically depressed patients would have insights. Usually lack of insight is more common in psychosis than depression. So most depressed patients know they're depressed. So they have insights. They know that they're not, they have low mood. So that's essentially your mental state examination. Okay, so once you've done your mental state examination, the next thing is to assess his risk. And essentially, what risk assessment entails is how safe is this patient? Is this patient at risk to himself? So risk to self, is he suicidal? Is he having feelings of killing himself? Has he got any particular plans? Has he thought about anything in a particular way, like hanging himself, overdosing, which this patient did? But you want to know, is he having an ongoing? Obviously, he was suicidal. He overdosed. He wanted to kill himself. We want to know, does he regret that action? Or does he feel like, oh no, I wish I had died? If he goes home, what's the likelihood that he's going to overdose again? What's the likelihood he's going to try to kill himself by drowning or hanging himself, or allowing a train to run over him, So is he at risk of neglect, self-neglect? Is he going to starve himself? Is he going to, keep his house very untidy, not wash his clothes, not have his bath? Is he at risk of self-neglect? And then you assess risk to others. If he's got carers, if his mom or his dad is caring for him, is there a risk of carer burnout? Because whoever is caring for him, is there a risk that they might be overworked and burnt out? Is he at risk of physically harming someone, stabbing someone, shooting someone? You have to assess all of that. Is there a risk from other people? Is there someone who is threatening to harm him in the community? You need to ask all of those. Sometimes you might go ahead to do a COVID risk assessment, risk of falls, but most likely in elderly patients, you are check if they are risk of falling, risk of having, DVT and pulmonary embolism. But in this scenario, most times you just have to do a risk to self, okay, suicidality, check how suicidal this patient is at the moment, and if it's safe to send him home or not. Additional history, you might need to ask, drug and substance use history. Is he using drugs? Does he use drugs? Does he smoke? Does he take, misuse alcohol? Any past psychiatric history, medication history? Is he on antidepressants? Has he ever been on antidepressants? Has he ever, had talking therapy, counseling sessions, things like that? Any past psychiatric admissions, for depression, for psychosis, anything? Any family history of mental health problems? Social history, who does he live with? What kind of support does he have? Okay. Then, if you think his risk of committing suicide, if you send him home, is low, if he has a low risk of, immediate, um, suicide attempts within the next 48 hours, you can send him home. But you tell him that, okay, if you think you're feeling this way, we advise you to call 999, which is ambulance service, emergency service, Of course, you can speak with the home treatment team, the crisis team. You can speak with the crisis team. They're available. You give him the contact of the crisis team. If he goes home and he starts feeling very overwhelmed, feeling suicidal, he can call the home treatment team or the crisis team and have a chat with them. The home treatment team might, arrange if they think his risk is now escalating to high risk of committing suicide or severe self-harm, then they might arrange an ambulance transfer back to the emergency department, or they might section him, they might say, okay, yeah, we don't think you're safe. If he doesn't want to go in, then they apply maybe the Mental Health Act and section him, which is detain him against his own will, and then involuntarily admit him into the mental health ward for treatment. So those are things that are available. But you also tell him to book an appointment with his GP because he might need to discuss, the need to start um, antidepressants. Okay, so you book an appointment with your GP, talk further about this. Your GP might need to consider starting you on an antidepressant. Check what he thinks about starting antidepressants, whether he's happy to consider that or not. Okay, tell him about things like talk walks, talking therapy. If he wants to, talk to someone about how he's feeling, that sometimes talking therapy helps, people that are suffering, with low mood and depression. So talk to him about the available services, that could help him if he decides to go home. And so essentially what you're doing is do the mental state examination, check his risk of repeat suicide, how safe he is, and then, inform him of available services. And of course, you need to do the safety net. If he feels overwhelmed, he needs to call the home treatment team or the crisis team. And if he's not able to get through to them, of course, he can call 999 ambulance service. Okay. So once you've done this, I believe 8 minutes will be enough to explore these, especially the risk assessments. Okay. So if you think this has been helpful in understanding how to approach this station on suicide attempt and depression, kindly leave a like, subscribe to my channel, share this station, the approach with your friends who are preparing for the PLAB 2 examination. Thank you very much.